Okay, so good morning, everyone. Gerry is on the East Coast, so he has already corrected me. I'm going to say good afternoon to him. My name is
Thank you.
Sheree Dixon, and I am the Program Director of Education Operations here at HASC. And I really want to thank you all for joining us this morning for our Healthcare Emergency Management and Cybersecurity webinar. Today, you will hear from Gerry Blass, who is the CEO of ComplyAssistant, and you will also hear from Tom Soto, who is HASC's very own Chief Information Officer. And they're going to share with you how your organizations can prepare for, respond to, and recover from like extended periods of downtime that can be caused by natural disasters, such as like fires, earthquakes, cybersecurity, and any other incidents. Before we get started and I introduce them, just a few housekeeping items though for you to know. Just to keep the flow going, I kindly ask that you hold all your questions to the end. You can feel free to jot them down, take notes, or you can just put them in the chat and somebody can read them out loud for you. We're going to take questions at the end, and you can simply unmute yourself to ask any question, or again, you can leave it in the chat and I will read your question out loud. I also want to let everyone know that this session is being recorded and you will receive a copy of the session recording as well as the presentation slide deck. And we're also going to send a quick session evaluation, very quick, no more than like 2 to 3 minutes to complete, just so we can get your feedback. It is important to us and it helps us to determine how to move forward with our education programs. Okay, now I am actually very happy to introduce our facilitators today. We have Gerry Blass, as I said, CEO of ComplyAssistant, and we have Tom Soto, who is our Chief Information Officer here at HASC. And Gerry and Tom actually have a very interactive webinar planned for you today. Throughout the webinar, you will see a couple of poll questions pop up, about 4 different poll questions at the beginning of a few slides. We're just going to ask for you to quickly participate, give your feedback, and then we will go through the responses together. So just a little information about our presenters. Gerry, as I said, is the president and CEO of ComplyAssistant. ComplyAssistant is a HASC endorsed business partner who provides cybersecurity services for more than 100 healthcare organizations. Gerry work focuses on compliance with HIPAA and other federal regulations. Gerry co-chairs the New Jersey, that's the accents you guys are hearing, Healthcare Information and Management Systems Society. And he also is a regular contributor to the Healthcare Compliance and Health IT publications. And Tom Soto, thank you, Tom, for joining us today. As I said, serves as HASC Chief Information Officer. And he brings more than actually 2 decades of healthcare IT leadership to this role. Tom specializes in business analysis, change management, and strategic planning with a strong emphasis on process improvement. Tom holds a certificate in information systems, security professionals. That's, a designated a global recognition certificate in information of security. I'm so sorry, guys. Also, Tom is a UCLA graduate, which is one of my favorite schools, and Tom is dedicated to leveraging all technology so that he can enhance operation in our facilities. And now I am going to hand things over to them.
Great. Thank you, Sheree.
Of course.
Okay, I'm going to share. And let me go back to here. See, it says, okay, meeting's being recorded. That sounds good. And I'm going to go into full screen mode. Okay, looks good?
Looks great, Gerry.
Looks good. All right. So thanks again, Sheree, and Sharita, and Tom. Great to see you. And thanks everybody for joining us today. So today's session, as Sheree mentioned, is about healthcare emergency management and cybersecurity. And coming into play with cybersecurity is also AI. The time frame we have today for this, we could take a month to go over this stuff, but we're going to narrow it down into 1 hour, including questions, which we can do. And then we can also get back afterwards if you have questions. We'll have that information for you at the end, how to contact us. And then we can also perhaps plan other webinars in the future that are focused on one part of our presentation today. So our focus today is how hospitals and health systems can better prepare for, respond to, and recover from disruptive incidents, whether they're caused by natural events, technical failures, or cyber attacks. As we go through the material, think about how these concepts can map to your own organization's emergency operation plan and day-to-day operations. Our goal is to give you a practical, actionable ideas that you can take back and incorporate into your current preparedness and resilience strategies. So engaging in emergency management in healthcare, emergency management is not a back office function. I'm sure that all of you know that. It's central to safe patient care, okay? And there's a poll coming up. Engagement means more than having a binder on a shelf. It means involving clinical, IT, facilities, leadership, and vendors in planning and execution. Effective emergency management requires continuous collaboration, regular communication, and a shared understanding of the roles and responsibilities before, during, and after an incident. As we move forward, we'll show how this engagement ties directly into cybersecurity and system downtime. So we should wait here, Cherie, right, for the results here?
Yeah, we're going to give you guys a couple of minutes to respond to the poll questions. I'm able to see that the first one, we have about 6 responses. Gerry, we have about 10 more minutes.
10 more minutes?
Sorry, 10 seconds.
Oh.
Guys,
I was going to say, I was going to go get a cup of coffee. Get a cup of coffee.
Yes.
Okay, here we go.
Yeah.
What aspect of healthcare emergency preparedness is your organization most focused on today? Cyber is 14. Okay, well, all of the above. 86. Okay. All right, great. It's good to see cyber across the board. So now, do I close that or? Okay, you close it. Great. Tom, any comments on that before we move forward?
No, all of the above is what I expected. So
Yeah.
it's right on target.
Okay, great. All right, so now we come here. Let me just come here. All right. So, healthcare emergency management team. The first side there on the left, preparedness and planning, begins with a robust EOP, which is emergency operations plan. And it has to meet regulatory requirements, but also reflects the realities of your organization. Think of it as a policy that is generic versus a policy that actually applies to your organization. That's key. This includes defining how you will respond to different types of incidents and conducting formal risk assessments, such as, well, one area is hazard vulnerability, another area would be natural, another area is man-made like cyber, and it's a risk assessment. It also includes emergency response coordination, activating command centers, maintaining continuity of patient care. Today, cyber safety is known as patient safety and lives. So that's pretty much a big logo now because it really does. It also includes emergency response coordination, activating command centers, maintaining continuity patient care, as I said, and ensuring clear communication. Business continuity, mitigation strategies, regulatory alignment, and documentation complete the preparation cycle. So mitigating healthcare downtime. Mitigating starts with recognizing that not all incidents are the same, but they have similar impacts. So whether you're downtime, whether it's whatever time frame it's down, or if it's extended downtime, can be due to cyber, a ransomware attack. It can be due to fires. I think you're all familiar with fires out in Southern California, hurricanes, different types of incidents, but the end result is actually the same impact. Your systems are down. So we must look at both natural and man-made causes and understand how each might disrupt the healthcare environment. The goal is to reduce the likelihood of downtime where possible, limit its duration when it occurs, and maintain safe care even under degraded conditions. Okay. So natural incidents are disruptive. Natural incidents, including hurricanes, floods, wildfires, and earthquakes, can create significant operational and physical challenge. Man-made incidents such as cyber attacks or utility failures can be equally disruptive. Both types of events can cause patient care delays, service loss, relocations, and compliance challenges. Extended downtime also makes it difficult to meet regulatory expectations and maintain financial stability. We've had examples, big examples of extended downtimes. One of them, and the most famous one, is Change Healthcare. Change Healthcare was nationwide. It was extended. I wouldn't be surprised if there's still some recovery going on. It impacted 130 million patient information, PHI. And it is the poster child for bringing attention to the threats that are out there, the vulnerabilities, the potential impacts. And that's basically the biggest one. Others include other big healthcare systems that were down for months. In the old days, a downtime was maybe 3 days expected. That was an emergency downtime was maybe 3 days. Now, weeks by months, and those impacts become geometric. I'm sure that most of you have heard of those kind of impacts, but it impacts every area of a hospital, including cash flow, patient care, the downtime procedures, the interdependencies of departments, communications, everything just goes out of whack. And the more time that goes on, the worse it gets. It's just not an experience that anybody wants to go through. There's no way. Okay, so next. The impact of healthcare incidents. So this slide categorizes the downtime risks and ties them to examples, such as hurricanes causing physical damage, ransomware causing IT lockdowns, supply chain failures causing equipment shortages, pandemics overloading systems. Understanding these categories helps organizations tailor their planning, drills, and mitigation efforts. So you can see on this list, we have natural, we have man-made. I think just about every type is covered here with the downtime risk and examples. And of course, for the wildfire, we've indicated the example in California, which was really horrendous. Enhancing resiliency. So preventing, here's another poll. Preventing extended downtime. Preventing downtime requires thorough risk assessment, hazard vulnerability analysis as an example, cybersecurity, risk analysis, etc. Clear downtime preparedness planning and regular training. When incidents occur, activating the hospital incident command system ensures a coordinated response. Afterwards, recovery and improvement activities, including after-action reviews, enhance resilience. Very important to have those after-incident reviews to determine what went right, what went wrong, and improving on that for the next time. So here we have a poll.
We have about 10 more seconds, and you asked, which EMT responsibility do you view as most critical during an outage? And the response? Let's see. Okay, I think we have communication management at 50%. Gerry?
So incident command, all of these obviously are important. Resource, post-incident recovery. We mentioned all that already, but communication management is getting the biggest percentage. There's nothing worse than having a major incident and having some confusion around the status of it day by day, especially if it lingers on. The staff need to know the current status. So there needs to be continuous updates to everybody so they feel that they understand what's going on right now. They understand what to expect in the future based on what's happening right now. and that can reduce some panic and give confidence that it's going to get better. So communications is I can see why it's 50%. It's very important. Okay, let's move on. So redundant data centers is the next one. Actually, you know what? This one is in preventing extended downtime. So I want to get back on the right train of thought here. Preventing extended downtime requires, well, actually, I covered that, so that's good. So now, actually, Tom, we're coming up to you, I believe, right here. Effective strategies.
Yes.
Yeah.
Yes. Thank you everyone for joining us today. I know we're all very busy. Healthcare is probably right now the number one attack cyber uh, cyber attack industry globally, not just in the United States, but globally. And also, Mother Nature is not getting any friendlier as well. So, as Gerry has indicated, for example, if you're not aware, there was a major outage today with one of our major um, internet services providers, and it took down some big sites like X and ChatGPT. Um, Also, there was a major U.S. health system last year that was down for 31 days. That meant canceled surgeries, diverted ambulances, and things like that. So, what we want to talk about is how do we prevent some of those things? How do we recover? And we'll look forward to that. So, there's a poll. Hopefully you are able to take that, and again, all of the above, and we're going to come and look at those right now. So let's see here. Okay, next slide, Gerry.
Sure. Oops. Here we go.
So we're looking at some of the strategies here that we can mitigate some of the vulnerabilities and risks involved with cybersecurity. And without going through all of these, but you know, redundant data centers, when we have a backup of our systems in a different location, if that one in our main location goes down, we can cross over to the other one. Cloud backup are essential, but we need to get those not only up and running, but tested. Testing those things is critical. We need to make sure that any real-time cloud backups are actually restored in a test. That is so important because I've seen so many times where, yes, we're backing up, but when it comes down to, oh, we need to restore, either the cloud backup itself has been compromised or there's been some issue that we could not restore. So that needs to be tested. Hardening systems, make sure things are patched. These are kind of common basic IT functions, but you'd be surprised when those things don't happen. And then there's a vulnerability that the hackers take advantage of. So these things can prevent a lot of the issues that we hear about, compromised facilities. You can turn a $10 million, 32 million or 32-day nightmare into a shorter incident just by having these things in place. Very important. I would venture to say that if one of these things is missing in your facility today, or if you don't understand what these are, mostly in the IT side of things, they need to be addressed. Gerry, can you go next one?
Sure.
Okay, I could spend probably the entire time just on this slide, so I'm going to try to go through some of the things here that are very critical. If we don't understand or know what a business continuity plan or a disaster recovery plan, or if you've never heard of that before, you really need to get on board to what these things are critically important about, because without these plans, the rest of the things are going to fall apart really quick. And how do we start those things? So I'm going to kind of do a little bit of identifying what they mean. I'm going to start with business continuity that really focuses on maintaining essential operations during a disruption, identifies critical services, processes, and resources that you need to keep the organization running. It includes procedures, manual workflows, communication, and coordinating across multiple departments. Disaster recovery plan is mostly focused on restoring IT systems, applications, and data after the incident, detailed backup strategies, recovery time, um, and objectives and recovery point objectives are important there. I'll talk about that in a second. But all that begins with what we call a business impact analysis. I'm using a lot of terms here, so hopefully we can go through them. But the business impact analysis basically identifies what processes, what are the most important to your organization, evaluate the potential impact and effects of disruptions to those, and then determine which systems, processes, resources are most essential, and then estimate the downtime and guide the recovery strategies through those. So those plans, again, we could spend multiple webinars just on how to do that. And there's organizations out there like Gerry's that can help your hospitals, develop these plans, test them, and review them. They need to be reviewed at all times. So, what is the RTO? So, defined recovery time objective. So, when we have an incident, we want to, we need to know the maximum acceptable time that a system can or application can be down before operations must be restored. So, in essence, how quickly do we need to recover that system or process? And then the RPO, the recovery point objective, what is the maximum amount of time, or I'm sorry, of data loss that we can accept measured in time? Basically, how much data can we afford to lose? Example, if I can afford to lose 1 hour of email, then I must back up at least uh, half an hour before that so that we can recover within that time period. Regular testing is critical in all these areas. So we want to make sure that our plans are updated. And one of the things that we want to include in these, and sometimes what I see in some of these plans, that we don't think about our third-party vendors in these testings. So when a change, a healthcare incident takes place, we need to know that these vendors have also the same continuity plans and disaster recovery plans in place so that we can rely on those vendors for our services, for their service. And bottom line is we want to ensure a rapid recovery and as fast as possible. We don't want to have these impacts because we did not plan ahead of time. So understanding the plans, if you don't understand it, if you never heard of one, if you haven't seen one, ask your team, your senior management, what are our BC and DR plans, because if we don't know them, we're not going to be able to test them. We're not going to be able to actually implement them when the time of an incident occurs. Next one, Gerry.
Okay.
Okay, resilience testing. So The only thing worse than a 12-hour EHR outage is finding out during that outage that half your staff never touched a paper chart or your walkie-talkies are dead. That's why we run regular tabletop exercises and live drills so that we know these um, by the back of our hand, basically, because we've seen unplanned incidents where we don't know how to communicate, where to communicate, and Joey kind of alluded to it earlier. But if we can't um, communicate even how to address these issues, we're going to be in big trouble. Um, so conduct these testing. We want to mimic live incidents. For instance, we can take um, a, a system, hopefully, and I know it's difficult in a hospital areas, but we can take a system down, see what happens, how do we address that, how long does it take for us to bring it back up. All these testings and drills will make the real life event much more um, uh, able to recover from. We Hospitals that drill effectively and consistently, we can reduce errors tremendously. We can divert those ambulances issues. We can address the attacks, things like that. So if you don't do these drills, you're going to be the one that's going to be in the news the next time, because the longer it takes to uh, uh, come back from an incident like this, it's going to be difficult to get those um, issues resolved, like diversion, patients not being able to have their procedures done, and things like that. Next one, Gerry.
Okay.
Okay, here are 4 cyber controls that um, when hospitals get hit, they're actually still able to function. So if you don't know what any of these are, the one that I want you to really understand is MFA. Everything should be right now. Anything that you log into, whether it's in the hospital, whether it's at home, your banking systems, whatever that is, it must have MFA. That's going to be a critical uh, defense against any compromised login and password. Because eventually it's almost inevitable where a login and password is going to get compromised, and either through phishing, some type of other social engineering attempt. But MFA will prevent that user or that attacker from being able to access your account. So I'm going to say MFA is no exceptions. There's one stolen password, and the game is over, because they can have access to multiple areas in your networks. EDR is endpoint detection and response. Think of back in the old days where we had antivirus or anti-malware uh, services like Norton, whatever that uh, system you used back in the day. Well, it's much more complex and much more effective beyond malware and anti-phishing, or I'm sorry, anti-virus. So these systems really today are relying on AI to recognize threats through anomalies into your networks. Things like if somebody's downloading a lot of data or uploading data into the cloud, and it's not normal for them to do that, these systems can detect that. So we want to make sure that we have the most comprehensive EDR available. And again, if you don't know what that means, this is really on the IT side of things, but still, we want to make sure that these things are addressed. Zero trust is basically don't trust and always verify. And that goes for not just users and their accounts, but also devices, networks, everything. So if we have a device, like we use a lot of laptops nowadays, we need to make sure that those devices have all the vulnerabilities addressed, the proper software on them, things like detection that if someone were to try to log in from, Eastern Europe, we can detect that, things like that. So, and then maintain a 24-hour operations center. These things are expensive. So I know hospitals were stressed, we're staffed, shortages, and one of the things that we can do is outsource some of these um, security services, like where they can handle the attempts, the network hacking attempts that come through that maybe we don't have the resources or the expertise to identify. It can get pretty complicated at times, but we can rely on these services to protect. One thing I do want to point out is we don't have these things in place. I'm going to pretty much guarantee that our cyber insurance companies are not going to um, give us policies because they're going to demand that these are in place to be able to, um, safely protect our network. So it goes beyond just uh, protecting us, but also, uh, we want to do some risk transfer to insurance. If we don't have these in place, we'll be denied coverage. And next one, Gerry. Here at HASC, I like to turn every staff member into a phishing, spotting, a procedure following pro through short, repeated, and real training. Um, I know, again, we're all busy, especially in hospitals. It takes, time off, whatever we're doing for our patients, but it's critical that we educate our staff. Um, we have what we call defense um, in depth, where we have multiple systems maybe protecting our networks. We have, firewalls, and we have those EDRs, and we have everything. But the bottom line, and the last layer of defense is going to be us, our users. So we need to educate as much as possible, and make sure that they can recognize those phishing attempts, report the incident, and then follow the downtime procedures as we've tested and trained on. Um, I like to put a what I call a downtime champion. Um, the go-to heroes that keep the patient care moving, with whether it's with paper charts, with runners, with analog phones, whatever it is during those downtimes. Again, trained, practice these things, and they'll make any event much more palatable when those things do happen. Build a see something, say something culture so that incidents get reported in minutes and not days. Again, education here, letting our users know that there's no wrong or mistake um, to address or ask a question about whether something is phishing or not. I always say send it to your help desk, send it to whoever is monitoring those systems, and be safe rather than sorry. And finally, make the manual workflows, make them fast, make them familiar, because when your EHR is dead, the muscle memory of doing paper charts is going to really help to save those lives. Um, when well trained people and unit means or equals dramatically less chaos, fewer errors, and patients who never feel the outage. Next one, Gerry.
Okay, Did you want to take this, Tom, or I can take it?
Go ahead and take it. I'll take the next one if you.
Okay. Um, so this one is focused on vendors because vendors have been known statistically to be the reason for a successful ransomware attack. The vendor and their clients get attacked. Change Healthcare, of course, is the biggest. We mentioned that. But it's actually 60% plus. And what that says is that you have to have strong vetting of vendors pre-contract. There has to be periodic vending of their controls because vendors can access PHI. If they become a business associate, it means they're either accessing it, storing it, or transmitting it. And so when they get attacked, it could go downstream to all their clients. And that's why I would say if I was to rank the top 2 vulnerabilities for attack, it would be the vendors. And now AI is being included in there as well. AI and cyber are crossing over into risk from a vendor standpoint. The vendors provide most of the, if not 90% or plus of the apps that are AI enabled. So you really have to vet on both sides. And the other big threat is as Tom mentioned, the insider, which is phishing. Because you could have all these controls in place, and all it takes is one employee to click on the wrong email, and it could bring down an entire network. It's scary, but those are the top 2. And everything else that Tom talked about is very important. And Tom mentioned that all those controls that must be in place to reduce risk are now not only part of the frameworks that we see today, frameworks being frameworks that identify what needs to be in place, that it's like a checklist, need to assess it, need to determine risk, where are there exceptions, where is their gap, where is their risk, and address it. So you have the frameworks, but the insurance companies actually pretty much have a framework of their own. And as Tom mentioned, they will have their underwriters look at answers to insurance questionnaires like MFA, multi-factor authentication, zero trust, all those controls that Tom mentioned. They're going to examine those attestations from a healthcare organization and come up with a premium price on the policy and what they're going to cover. Now, if those attestations are not totally correct, and there's an event, and there's forensics to determine what happened, and in that discovery, it's determined that some of those controls that were attested to were not in place, insurance company will come back and either say, well, we're only going to cover this much of it, or we're not going to cover any of it. So you can't get a false sense of security just by the fact that there's a policy in place. It has to be reviewed just like a regular framework that covers cyber, AI. There's HIPAA security. Our company personally belongs to an organization known as HSCC, which is the Health Sector Cybersecurity Council, hscc.org. There's a lot of information on there that would be very helpful to everyone here today, IT in your organization. Some folks in IT and other areas should actually consider joining HSCC to stay on top of the latest and greatest with all of these issues that we're talking about today. I can tell you that I belong, and it's been a very valuable experience for me and for our company to understand the latest and greatest coming out of the government. So effective vendor oversight, of course, downtime policies from them, annual audits of them, pre-contract audits of them, risk reduction by implementing strategies. The vendors should be required to prove their responses to vetting. Just like the insurance companies vet the hospitals should vet their vendors. And I can tell you that another reason why this becomes such a big vulnerability, there's a lot of vendors, and there's a lot of vendors who have different categories of risk in what they are doing with your PHI. The hospitals tend to have budget restraints. That's pretty common. The restraints could be on resources, it could be on money to spend on this stuff. So that being the case, the managing of vendors might be the straw that breaks the camel's back sometimes in staffing, being able to be properly resourced to vet these vendors. And I'm really spending time on this because this is where a lot of the breaches have occurred. To vet these vendors is going to take automation. It's going to take resources, and it has to be done. If there's an event like Change Healthcare, the government is going to investigate organizations that were impacted to determine if they did have a third-party vendor vetting program in place for risk management. And if they don't, they could get dinged. So it's a compliance issue. It's a risk reduction issue. And Tom, so far we haven't mentioned the G word, which is governance.
Mm-hmm.
But all of the stuff we're talking about requires governance. A security steering committee, or it might be called cybersecurity governance committee, AI governance committee, led by leadership and all areas of the healthcare organization. It's an enterprise-wide governance. And it is where issues, vulnerabilities that exist could be identified. CFO should be on there so they understand where the gaps are and the risk and what it's going to take money-wise to invest to reduce those risks. The time is now that these problems and issues become so big that it involves the entire enterprise. It used to be thought of as, in some cases, some of this stuff is just an IT issue. No longer is that the case. Yes, IT, and Tom, with his role as CIO at HASC, has to spearhead the controls, the technical stuff, and also to have the disaster recovery plan. That plan is IT driven for the most part. The business continuity plan is enterprise because that involves every single area of the hospital. What do we do if we're down? How do we communicate with other departments? Overall process for emergency operation plan and teams and everyone being on top of what is the actual status of risk and controls. And, it has to be open-mindedness around proper communication, unbiased and truthful, honest, no worries about politics. This is the perfect world that everybody needs to live in order to have proper governance over all this stuff. So that's my thing for today. Tom, you going to pick it up here again, or should I? I think you can here, right? Or you want me
Yes,
to?
I can do it.
Okay.
So communication is critical. I can't emphasize that enough because the thing that's going to fail first is your digital comms. So we need to plan like they've already failed, and what do we do when that happens? I would suggest you stock, charge, train on walkie-talkies, analog phones, the ones that are actually have a landline to it, runners, any whiteboards, basically any tool that does not require a password. Train on those, know how to use them in an incident. It's going to be something that, in a true crisis, the hospital can still communicate. Test them every quarter in real drills because the tree that works on paper but fails at 2 a.m. is worthless. So train how to communicate without email, without your cell phone, without your voice over IP telephone system. It could be just sending one person to the next department back and forth as a runner. So train that to that person, know where to go, who to talk to, things like that. So practice that so that when something does happen, We're not just running around trying to figure out what do we do next.
Hmm.
Next one, Jerry.
Okay.
Kind of talked about insurance already,
Hmm.
but
Yeah, we did.
I'm gonna say really understand your policy. Most standard policies are not going to have um, what we need, maybe in an extended downtime through ransomware. So really, really important to read the fine print, what they really cover or what they don't cover, and as Jerry mentioned, what they expect our hospitals to have in place to prevent these type of incidents.
Hmm. And Tom, if I
Um,
could just mention something real quick.
absolutely,
So in looking at the policies, the insurance should cover extended downtime. It should cover data restoration, forensics, and regulatory costs. Financial modeling exists to help organizations understand potential downtime impacts on revenue, labor, and cash flow. So they can prepare appropriate reserves and reimbursement strategies. So just from a high level, those are the things that should be taken into consideration with insurance.
right. So I'm going to say run those numbers now. For instance, what does 14 days of zero revenue
Mm.
plus a $10 million restoration cost? And be prepared to, have those in reserve if possible,
Hmm.
because, in an incident, it's going to be critical that you're able to function financially as well. Next one, Jerry, I believe
Okay.
might be one of the last ones.
Yep. Getting there.
So
I
this is,
think this is also, sorry, where we have our last poll
yes, there's
question.
a
Oh,
poll
yeah.
question
Mm.
here.
Good.
Please, yeah, please go ahead and answer the questions. I'm going to go ahead. Just kind of a 7-move checklist that turns, a catastrophic week-long outage into a manageable incident. With redundant backups, real cyber defenses, tested recoveries, trained staff, lockdown vendors, playbooks, analog communication that don't fail. If you have these 7 things in place, we can keep caring for our patient no matter what hits. So I think the big key takeaways here on this slide, downtime isn't an IT problem. It's really a patient safety emergency. So we need to treat it that way. And I know Jerry's mentioned that earlier. The hospitals that recover the fastest do all these 7 things without exception.
Mm-hmm.
Train your people like the next shift depends on it because at some point it really might. And then, we talk about vendors, they don't get a pass. If they can't prove they can recover with you, they really should be replaced. Digital comms, they'll fail fast first. Like we said, walkie-talkies, runners, etc. Insurance is useless if it doesn't cover the weeks of downtime and full restoration. So again, look at those policies. And finally, um, train and educate our everybody because what I like to see is maybe a 1-page tested playbook of how to recover from an incident rather than a 300-page plan that lives on someone's shelf. Um, make it live, make it real, test those things in real time if possible. I know, again, we're stressed for staff, we're stressed for just our time and resources. But if we don't do these things, when the incident happens, it's going to take longer. It's going to be more effect in the facility, and ultimately our patients will be affected as well. So take the time. There's a lot here. We've gone through so many what I call disciplines that we can spend, inordinate
Mm-hmm.
amount of time just individually. Uh, but I think it's important that if we understand these and get these areas up and running, we the better chance we have of um, uh, recovering from a disaster, whether it's natural, whether it's cyber. Our hospitals will stay open, our patients will stay safe, and we won't make the front page of some news story. So, um, again, make sure, please, and that we try to implement these as consistently as possible. Gerry?
Yeah. The other scary phrase that I kind of hate to say, and probably everybody hates to hear, is that it's usually a question of when, not if, um, which is scary. So all an organization can do is its best to go through all this stuff and try to reduce risk, understand what to do when it occurs, and get through it. And Tom, you mentioned co-location and where that really comes into play. Co-location of, let's say, an EMR. So let's say it's on premise and it's also um, in the cloud in something like AWS or Azure, which is the two major clouds. If a downtime occurs on premise, figuratively, you can flip a switch and be into the cloud. The cloud is kept up to date with the on-premise, so it's like a smooth transition. Should be, like you said, it should be tested. Um, and so the conversation around extended downtimes and paying the ransom can be minimized by having that switchover occur real time. So you're not down in an extended downtime, maybe on premises, but now you're operating in the cloud. And when that's all fixed, you go back to on premise. Is it cheap? No, it's not cheap. It's an expensive control, but it's one that, in the event of an incident like an extended downtime, that could be much more expensive than the cost of implementing that control. Okay. So continue here. Oops. Yeah, I got to go to here. Okay. We this is pretty much a recap of everything we've talked about, this slide. Everyone gets a copy of this PowerPoint, so the information that's in here is, something you can review at any time after the fact. So that's why this is here again as kind of a recap. And you can also, Tom and I are always available. We have nothing else to do in our days but to wait for your call or your email. Right, Tom?
Absolutely.
What,
And,
what?
and seriously,
Yeah.
here at HASC, we're always available for our members. So,
Hmm.
always feel free to reach out to us.
Yes. I wanted to also add that you guys will receive a copy of this information, and I will, in the body of the email for you guys, make sure that you have Gerry and Tom's contact information so that you can reach out to them directly. And if
Yeah.
anyone has any questions, I think I saw a question come up in the chat. Let me check.
Yeah, something.
Oh, no,
Yeah.
Paula, you were saying that you did not see the
Oh,
poll question.
of
Okay.
course.
Sorry about that. We finished that one. Are
Hmm.
there any questions for Tom or Gerry today?
Tom and Gerry, yeah.
Yeah. I know we cover a lot of material and maybe kind of fast as well, but if you have any further questions, feel free to reach out.
Mhm.
How we can help. Again,
Hmm.
at HASC, we are here for our members. We will do whatever we can to assist.